Thanks, Damien. Michelle and I would just like to begin with an acknowledgement of country. So we acknowledge the traditional owners and custodians of the lands on which we stand, to which we belong, on which we live, and where we provide services, the creators and holders of unique knowledge systems. We acknowledge the sacrifices that have been made and the wisdom gifted to us, which has enriched our lives and that of the nation. So I'm joining from Cairns, so I'd like to acknowledge the Yurrugunjeri and Yidinji people. I hand over to Michelle.
And thank you. I'm joining from Brisbane, so the Turrbal and Yagara people. Thanks for having us. Okay, so to give you a brief overview of what we'll be looking at today, we'll be looking at the nutritional strategies in youth-onset type 2 diabetes. And in terms of overview, we'll be looking at the importance of nutrition care and goals of medical nutrition therapy, the contributors to overweight and obesity, dietary assessment, lifestyle interventions, and considerations when working in remote communities. So type 2 diabetes involves complex interactions between genetics, environmental, metabolic, and population-specific risk factors, resulting in hepatic, adipose, and muscle insulin resistance. As a more aggressive condition, youth-onset type 2 has a faster rate of deterioration of beta cell function compared with type 2 diabetes in adults. And diabetes and obesity-related comorbidities such as retinopathy, nephropathy, dyslipidemia, sleep apnea, hypertension may be present at diagnosis and progress more rapidly than either youth-onset type 1 or adult-onset type 2 diabetes. And when compared to peers without diabetes, adolescents with youth-onset type 2 are predicted to have a 15-year reduction in lifespan. Overweight and obesity are significant contributors to the development of type 2 diabetes as a result of excessive caloric intake, increased sedentary and reduced activity, resulting in surplus stored as fat, and may exacerbate the physiological insulin resistance associated with puberty. So obesity and lifestyle are major modifiable risk factors in youth-onset type 2, and others include mood, chronic stress, and sleep-related disorders. Diet and exercise interventions are essential for effective early and ongoing management, and especially in the context of limited pharmaceutical options in children and adolescents. The primary goal of medical nutrition therapy is weight loss in pediatrics with obesity and comorbidities such as type 2 diabetes. And weight management focuses on nutrition and physical activity to prevent further weight gain in those with BMI at the 85th to 95th percentile, or weight loss for those above the 95th percentile for BMI while maintaining linear growth. The aim is to reduce total energy intake to achieve 7% or more decrease in excess weight. And in terms of the rate of weight loss, a recent scoping review by Ullman and colleagues in 2021 described the current guidelines for the dietary management of pediatric obesity and severe obesity, recommending ranges from 0.4 kilos per month to 0.9 kilos per week for children, and from 0.5 to 2 kilos per month to 0.9 kilos per week for adolescents, or between 5 to 10% of body weight. We also aim to achieve euglycemia and glycosylated hemoglobin at less or equal to 6.5% to address comorbidities such as hypertension, dyslipidemia, nephropathy, liver disease, and to prevent and treat acute and chronic complications of youth-onset type 2 at every opportunity. The National Aboriginal and Torres Strait Islander Health Survey in 2020 reported the current status of overweight and obesity in children aged 2 to 17 years based on the BMI information reported. 38% were overweight or obese, and this reflected 24% in the overweight category and 14% in the obese category. For males, the highest BMI was reported in the 12 to 13-year age group, and for females, the highest BMI was reported in the 2 to 3-year-old age group. Overweight and obesity was found to increase with age at 42% in the 15 to 17 years and up to 59% in the 18 to 24-year-old age group. Common themes contributing across both our First Nations people and cross-culturally is inadequate dietary variety, a dependence on processed or packaged foods, a grazing eating pattern, poor mealtime routines and skipping meals, inadequate opportunity for incidental exercise, poor sleep hygiene, and excessive screen time. But contributors to overweight and obesity are not just dietary related, and that also needs to be considered. So based on the Aboriginal and Torres Strait Islander Guide to Healthy Eating, which is an adaptation with traditional Indigenous foods, the survey found that in 2012 to 2013, 41% of total daily energy for Aboriginal and Torres Strait Islanders came from foods and beverages in the discretionary category, or sometimes foods. And this equated to an average of 6.1 serves per day, with the majority coming from alcoholic beverages, soft drink at 9.1%, potato products, pastries, cakes and muffins, and confectionery, with less energy obtained from discretionary choices in remote areas compared to non-remote at 35% versus 42%. Of those who consumed sugary beverages, 24% of those aged 15 years or older had daily consumption. Those aged 2 to 14 years, 20% of which usually consumed sugar-sweetened drinks daily. 63% usually consumed sugar-sweetened or diet drinks at least once a week. And this was higher for people living in remote areas versus non-remote. In those aged greater than 2 years, there was reported 75 grams of free sugar per day consumed, which equated to a 14% of the total energy. And this is 50% more than the World Health Organization recommendation, and 67% of which came from sugary drinks. It was highest among older children and young adults. Teenage boys aged 14 to 18 years had an 18% of their total energy intake from free sugar, and free sugar intake was 12 grams higher per day among those living in non-remote areas. In terms of water intake, an average of 1 litre per day of plain drinking water was reported, and this would be the appropriate amount for a toddler aged 1 to 3 years of age. For grain foods, 25% of which came from whole grain or high fibre varieties, which is less than the recommendation at 50% of the diet. And only 7% of children aged 2 to 14 years met the 2013 dietary guidelines for vegetable intake. In the nutritional assessment of youth with type 2 diabetes, weight, height, and BMI percentiles and Z-score for age are used to determine overweight and obesity status. It is important to note that BMI is not static in children and adolescents, and is based on the child or adolescent's age, so it changes as they grow. BMI has limitations in that it cannot differentiate between muscle and adipose tissue, and therefore cannot differentiate between excess adipose tissue and increased lean body mass when clarifying a child as overweight or obese. Additional risk factors for children and adolescents of Indigenous backgrounds exist and include a BMI of greater than or equal to the 85th or 95th percentile, respectively, and or a waist circumference to height ratio of greater than 0.5. Waist circumference is another adiposity measure, and it indicates abdominal fat accumulation, and it may better predict cardiovascular disease and mortality, particularly if the BMI is within a healthy weight range. And in adults, an increased waist circumference is a predictor of diabetes, hypertension, high cholesterol, and cardiovascular disease. The waist circumference is an essential component of metabolic syndrome in children and adolescents aged 10 to 16 years. And this is a definition endorsed by the International Diabetes Federation. However, intermeasurement variability of waist circumference measurements can affect classifications and is not routinely used in clinical practice. The waist circumference cutoffs to define central obesity in children and adolescents based on multiple populations in different regions have also not been proposed. If we look at weight history, gathering early weight or growth history is also important. Adiposity rebound, which is looking at the increase in BMI in the first year, followed by a fall, and then a second rise in BMI at about 6 years of age. An early BMI rebound before 5 years of age carries a higher risk for adult obesity. Large body size and rapid growth outside of the norm range during the early years of life are both associated with a risk of overweight and obesity in childhood and adulthood. So with the higher BMI in females, as reported in the survey, in that 2 to 3 year old age group, is therefore a perfect opportunity for intervention. We also look at relevant test results. So whether working in a multidisciplinary team or in isolation, it is important to be aware of appropriate markers and tests to request in an overweight or obese child, especially with physical markers for insulin resistance. The biochemistry will guide lifestyle intervention and measures of progress outside of just focusing on weight outcomes alone. It also gives us a guide to target for HbA1c, which should be at levels less than or equal to 6.5% and should be, they're recommended to be tested every 3 months. And this is without causing hypoglycemia and or undue treatment burden. So I'm not going to go through all the dietary assessment in the youth onset type 2. Some of these we've covered already, but it's important to have a look at whether there's any previous dietetic intervention, recall what the success or failures have been, and particularly with our cohort looking at food security. Food insecurity is associated with higher obesity prevalence among vulnerable populations, and initiatives need to improve food security and food systems to address obesity under nutrition. And Caroline will touch on these later in the piece. In terms of triggers to disordered eating, there is no evidence to support that talking to youth regarding weight will cause an eating disorder, but there needs to be screening for adolescents who are obese, as is consistently reported to be high rates of depression, anxiety, and binge eating disorders with overweight patients. Eating disorders, whilst generally rare, however, have been increasing. They carry one of the highest mortality rate risks of any psychiatric disorder. And dieting as a self-reported practice to control weight has been associated with an increased risk of disordered eating and the development of eating disorders in observational studies. Work by Jabil and colleagues in 2019 found that the structured and professional run obesity treatment was associated with reduced eating disorder prevalence, eating disorder risk, and symptoms. And I've included their work in my reference list if you'd like to read further, as this in itself could be a whole conversation topic for a webinar. And then I want to just draw focus to medications. So considering the medications that may contribute to weight gain, undermining lifestyle behaviours, or require adjustment with weight loss. So namely metformin, which has been shown to have small but statistically significant decrease in body mass index when used for insulin resistance and abnormal glucose metabolism, but also insulin. So comparative standards in terms of dietetic practice would be looking at the energy needs based on the Schofield equation and looking at either adjusted or ideal body weights. And we would be looking at estimated proteins based on the NRVs, the carbohydrate needs, fibre needs for age, fluid based on adjusted body weights, and micronutrients that are the nutrient reference values for age. And so these are what we use in our clinical practice to guide our interventions, but also to tweak as we go. So in terms of lifestyle interventions, once metabolically stable, the first line treatment in youth onset type 2 is diet and physical activity with metformin. And the benefits of weight management interventions, there is strong evidence supporting the benefits secondary to weight management, which are motivating tools to encourage and change positive lifestyle alterations, such as reduced risk of hypertension, dyslipidemia, cardiovascular disease, type 2 diabetes, obstructive sleep apnea, reduced risk of depressive symptoms, anxiety and bullying, secondary to improved quality of life, self-esteem and self-confidence. So I'd like to go through some of these briefly, and I'd like to also acknowledge the Healthy Kids Start program through Good Start, who have developed some of these resources and gave me permission to use the images today. So we focus on healthy habits, and this encompasses 8 areas of life. And to begin with, we talk to families and kids about how they think they're going in each of these categories, and we try and individualize the interventions that we're providing. A multi-component approach to the healthy lifestyle for weight management and modification is the priority with a type 2 diabetes diagnosis. And the cornerstone of managing the child and adolescent with overweight and obesity is family-centred. And this approach includes dietary change to improve nutrition, daily physical activity that is enjoyable, accessible, and of an intensity that enhances cardiometabolic health and behaviour modification. So when we're looking at these healthy habits, we're looking at swapping those sugary drinks for water. We're looking at healthy portion sizes. We're looking at healthy carb portions, so replacing high GI carbohydrates with low GI carbs. We're looking at meal routines, achieving 5 serves of veggies daily, choosing healthy snacks, reducing sedentary time, and achieving 60 minutes per day of moderate to vigorous physical activity, including muscle strengthening, exercise 3 times per week. And this helps to improve muscle mass, body comp, insulin sensitivity and management. And we also focus on sleep patterns. So sleep deprivation and obstructive sleep apnea in adolescence is associated with obesity and metabolic syndrome. And strategies to improve sleep hygiene, such as early and consistent bedtime and wake times, and reduced evening exposure to electronic media can assist with this. So we're looking at positive role modeling and promotion of family-based problem-solving skills. And the long-term behaviour change requires both family and community-centred approaches to address the physical activity, the cardiovascular risk, and excessive weight gain. We also use the laboratory assessment to specifically address and focus our intervention. So looking at dyslipidemia and fat, so reducing total dietary fat, reducing saturated fat to less than 7% of the total energy intake, avoiding trans fats. And if after 6 months of lifestyle change, the LDL cholesterol is still high, the recommendation is to look at statins. Hypertension, so looking at hypertension and guiding our intervention in terms of aiming for healthy weight, being physically active, eating a healthy balanced diet, and eating less salty foods. So what is the evidence for intervention? So the dietary intervention supported by some evidence looks at healthy eating advice with appropriate portions and calories. It's based on the Australian Guide to Healthy Eating, and it demonstrates effective modest weight loss in adolescents in the short to medium term. In terms of low GI diets, high GI foods are replaced with nutritious and lower GI foods to reduce glycemic load alongside appropriate total energy intake. And this demonstrates significant reduction in waist circumference, BMI Z-score, and insulin resistance if combined with the appropriate total energy intake. And a low GI diet alone significantly reduces insulin resistance. So our first line of treatment, once metabolically stable, is lifestyle intervention with metformin. However, in many youth with obesity, they don't respond to conventional treatment, and many youth with type 2 diabetes do not respond to traditional diabetes therapy. The Today study comparing type 2 diabetes treatment options in 699 10 to 17-year-olds in the US demonstrated that lifestyle modifications with metformin led to meaningful weight loss for only a third of adolescent participants, and half of participants experienced glycemic failure after 12 months of treatment. So less common interventions. The interventions requiring further evidence regarding long-term outcome consist of very low carb diets, typically 20 to 50 grams per day. They've been shown to improve hyperinsulinemia in adolescents with obesity. Very low energy diets typically consist of 800 calories per day and less than 50 grams of carbohydrate, aiming to induce ketosis. They include high quality protein, and their impact has been shown to achieve short-term rapid weight loss while preserving lean body mass, decreasing body mass index, and improving the HbA1c levels in adolescents with obesity. These are, however, contraindicated in pediatrics. However, with severe obesity, the risk versus benefit needs to be considered. If we look at intermittent modified fasting, the carbs is moderately restricted overall to account for 26 to 44% of total calories. And this has been shown to be effective in the adult population for weight loss, reduced body fat, improved insulin sensitivity, and other risk factors, but there's limited evidence in adolescents. The Medical Journal of Australia, Australasian Paediatric Endocrine Group guidelines suggest that very low energy diets can be safely and effectively used with a carefully monitored weight loss program within an MDT. And these interventions show success, but they require further evidence regarding long-term outcomes. So the few guidelines regarding long-term outcomes, the few guidelines recommended intensive dietary approaches such as very low energy diet and low carb diets. They were for management of obesity and obesity-related comorbidities as a final stage tertiary care intervention. And so the overall guidance of the use of dietary approaches for the management of obesity and severe obesity is quite scarce. And if the conventional lifestyle interventions aren't successful, what options are available and what evidence exists for their use in children and adolescents with type 2? So Gao and colleagues conducted a systematic review in 2019. They included 24 papers. Only 2 evaluated the use of a very low energy diet in young people with type 2 diabetes, and they consisted of a chart review and a pilot intervention. Now, both studies demonstrated significant weight loss, significant improvement in glycemia with an HbA1c of 8.8% down to 7.4. They demonstrated normalization of 2-hour fasting glucose and HbA1c in 4 out of the 5 completers in the pilot, and reduced medication use. So both studies reported all except one participant ceased insulin and remained insulin-free for the duration of the follow-up. And that particular person had diabetes for a duration of roughly 3.25 years. So this highlights that the very low energy diet program is an effective intervention for weight loss, and it may be a feasible alternative treatment for young people by and in itself. But authors of the pilot also suggested that the implementation of a very low energy diet program early following diagnosis of type 2 may be an important consideration when aiming for diabetes remission, recommending a window of within 6 months from diagnosis. However, that little is known whether the remission of diabetes was maintained beyond that 6-month post-intervention. So what is the appropriate macronutrient distribution? Well, the jury is out in terms of the appropriate macronutrient distribution. 3 different interventions are displayed on screen with various carb, protein, and energy. And a recent study by Garnett and colleagues looked at the optimal macronutrient content of diets for adolescents with pre-diabetes. And the objective was to determine the efficacy of 2 structured lifestyle interventions, both differing in diet macronutrient composition on insulin sensitivity. And participants were overweight or obese. They were aged 10 to 17 years with either pre-diabetes and all clinical features of insulin resistance. At baseline, the adolescents were prescribed metformin and randomized to a structured diet, which was either high carb or moderate carb with increased protein. And the program commenced with within a 3-month dietary intervention, and then with the addition of an exercise intervention in the next 3 months. So when they looked at the results after 6 months of intervention, both insulin sensitivity and BMI on the 95th percentile was significantly lower than at baseline. However, the diets had no differential effect on the change on any outcome measurements at any time point. The lack of difference between the treatment groups was not related to difference in baseline characteristics or adherence to the physical activity intervention or metformin therapy. So with lifestyle interventions, we see positive outcomes, but not all respond. And individualized medical nutrition therapy is just as important to work with families to advocate for the intervention that will best suit the practicality of their situation to achieve goals, results, and outcomes. And before I pass on to Carolyn, in terms of bariatrics, the APEG MJA screening assessment and management of type 2 diabetes guidelines recommend the use of bariatric surgery for selected post-pubertal adolescents with youth-onset type 2 with severe obesity with a BMI of greater than 35, who have difficulty managing glycemia and or comorbidities despite lifestyle and pharmacological treatment. So we don't have too much time to delve into bariatrics. And again, this is a topic that would warrant its own discussion. But Alman and colleagues identified that intensive dietary approaches may offer a safer, less invasive and non-permanent approach compared with bariatric surgery. The very low energy diet is often used prior to bariatric surgery to improve post-surgical outcomes, but less frequently used as a standalone treatment approach. So overall, where intensive dietary approaches have been recommended within guidelines, information pertaining to the practice implementation of these interventions is lacking. And the guidelines also highlight a lack of evidence relating to specific dietary approaches beneficial for the management of type 2 diabetes in youth, representing a really important area for further research. So the very low energy diet may provide an immediate step between the conventional lifestyle intervention and bariatric surgery, particularly with adolescents with a severe obesity, but a broader evidence base is required to inform future guidelines for the management. And keeping in mind the practicalities of the very low energy diet, so motivation, side effects, barriers and challenges, and the safety in use that do need to be considered. The RISE study showed that short-term insulin therapy in newly diagnosed adolescents with type 2 diabetes was not successful in halting the progressive deterioration of beta cell function. And within 5 years of diagnosis, more than 50% of adolescents with type 2 diabetes require insulin. So perhaps a more aggressive dietary approach is warranted in type 2 diabetes within 6 months of diagnosis as a crucial period to affect change and perhaps remission, but whether this is maintained and perhaps maintained in the longer term has not been demonstrated. So individual goals and motivators identified by the child and family with individual medical nutrition therapy is important, and not only focusing on weight, but also those other outcomes of progress, including improved self-esteem, confidence, improved family functioning, reduced hunger and demands on food, increased capacity for self-regulation. Okay, I'll now pass on to Caroline to discuss considerations from working in remote Aboriginal communities.
Thanks, Michelle. Sorry, I'm just having trouble getting my video started. Oh, yeah, there we go. So today I will discuss some of the significant challenges that people living in remote Aboriginal and Torres Strait Islander communities experience in terms of being able to access nutritious food and consume a diet that supports good health. So because I'm currently working in Cape York, so the next slide's got a map on it. So it just sort of shows like the remote communities in which we work, and I'll be using Cape York as a reference, as an example today. So one of the main considerations is food security. This is a significant barrier to people being able to achieve an optimal diet. So on the slide is a definition of food security developed by members of several remote Aboriginal communities throughout Australia. So the land and the sea is our food security. It is our right. Food security for us has two parts. Food security for us is when the food of our ancestors is protected and always there for us and our children. It is when we can easily access and afford the right non-traditional food for a collective health and active life. When we are food secure, we can provide, share, and fulfill our responsibilities. We can choose good food, knowing how to make choices and how to prepare and use it. Sorry, Angela, did you want to, you've got your hand raised.
I'm sorry, no, I needed to raise my hand for Damien for something. Sorry about that.
Oh, no, that's all right. I'll just continue. Yeah, so Aboriginal and Torres Strait Islander people over tens of thousands of years prior to invasion had a diet that supported community connectedness, good health, cultural and spiritual well-being, and sustainable land use. Traditional food practices have since been extensively impacted by European invasion and settlement, displacement from traditional lands, forced reliance on poor quality ration foods, limited financial independence, and a breakdown of cultural knowledge has led to the high rates of food insecurity that we see today. So across Australia, more than 1 in 5 Aboriginal and Torres Strait Islander people are reported to live in a food insecure household. So this is even higher in remote areas, with 31% of Aboriginal and Torres Strait Islander people reporting food insecurity. People living in remote areas experience higher rates of socioeconomic disadvantage and poor health compared to urban areas. For example, Cape York is classified as very remote, and the cost of food is 30% higher while the median income is approximately 30% lower than urban areas. So this means that people are spending a higher proportion of their total income on food, and is concerning given the level of inadequate real employment opportunities. Accessibility to food is a major challenge, with remote stores confronting higher freight costs, reduced economies of scale, and maintenance issues, which impact on the affordability and availability and quality of the fresh food. Additionally, reported issues of overcrowding and inadequate household infrastructure can impact on the safe storage, preparation, and consumption of food. Cape York also faces the challenge of food supply being impacted during the wet season, where communities may become inaccessible by road for up to 5 months of the year. Lack of food security causes hunger and anxiety related to food shortage in the short term, and serious health consequences related to malnutrition and chronic disease such as diabetes in the medium to long term. I'll now talk through some of the strengths and other challenges that relate to nutrition, just on the next slide. So Aboriginal and Torres Strait Islander culture can be categorised as communal. So the focus is on families, the community or group, rather than the individual. Sharing food with family is a cultural obligation that can act as both a buffer to food security and a potential contributor if sharing food leads to running short themselves. There can be many carers for one child, with aunts and grandparents and sometimes older siblings also playing a role. It is therefore important to make sure that we're sharing all nutrition information with the entire family, so that they can support each other to provide healthier meals while also involving the child and youth. So a recent paper exploring differences in perceptions of child feeding practices between parents and healthcare professionals found that Aboriginal and Torres Strait Islander parents highly valued independence in food behaviour, but were also conflicted with the easy access to unhealthy food in remote communities. So this easy access to unhealthy food and inadequate food storage and kitchen facilities are major challenges to achieving optimal diets for children. Traditional foods are still highly valued by people living in remote communities. However, access varies. So loss of traditional land and disruption of traditional food gathering practices has resulted in increased dependency on store foods. So it's estimated that Indigenous people in remote areas now rely on store foods for up to 95% of their energy needs. For example, in a study exploring consumption of traditional foods in 20 remote communities in the NT, 89% reported consuming a variety of traditional foods at least fortnightly, and 71% at least weekly. 76% reported being food insecure, with 40% obtaining traditional food during this time. So traditional foods are therefore both a cultural activity and a coping strategy to food insecurity. Community-based strategies to increase access to traditional foods could include assistance with transport, such as a bus, and working with local ranger groups. So some of the resources that we recommend. So visual resources are a great way to overcome language and cultural barriers. These resources displayed here are great for providing health and nutrition messages visually without oversimplifying or losing the complexity. So the Good Food for People with Diabetes is a booklet that steps through type 2 diabetes and recommended diet and lifestyle changes. It can be adapted for use for children and teenagers. And then the Healthier Living for Children and Teenagers Above a Healthy Weight is another NT resource that is specific for children, and a lot of the lifestyle messages overlap with those that would be for youth with type 2. And then the Tuapuna Pima resources are both great visual references that can support dietary advice using foods commonly consumed in remote communities. And the final one is a cookbook that we often use when cooking in community. It's got some visual instructions using ingredients that are found in remote stores. So I'd just like to touch on some of the work that's happening in remote communities to improve the supply and quality of fresh produce and promote healthy food choices. So I'll talk through one on the next slide called Healthy Stores 2020, but I'd also like to highlight a recent Opuna project, the Healthy Communities, that aim to engage local governments, community leaders, organisations and community members to create supportive environments to reduce sugary drink consumption. So there was a social marketing campaign that aimed to reinforce these messages around healthy drink choices, which coincided with the environmental changes that promoted water. So they found that awareness of social marketing messaging and increased availability of healthier drink choices contributed to positive changes in drink consumption. Enabling factors included community involvement, aligning implemented activities to the community readiness, and a focus on positive messages. So now I'll talk through the Healthy Stores 2020 project, which was co-designed with ALPA, who are an Aboriginal-owned store group. So the project was about restricting the merchandising of unhealthy products while allowing for promotion of healthy foods and drinks. The overarching aim was to reduce the volume of unhealthy items purchased and hence the amount of free sugar purchased. 20 store businesses agreed to participate and were allocated to the 12-week strategy or to usual retail practice. In 12 weeks, across the 10 strategy stores, they found that 1.8 tonnes less sugar was purchased through foods and drinks. So that's the equivalent to the weight of a large car. There was 7.5% less sugar from confectionery and 13.5% less sugar from soft drinks. So in stores that removed large size soft drinks from the fridges, there was a 21.5% reduction in free sugars from soft drink purchases. Importantly, there was no change to the store profits and managers were practically able to implement the changes. So the success of these results demonstrates a clear correlation with the store environment and its influence on the purchase of specific goods. It highlights the important role that stores play in remote communities and the potential for them to have a positive impact on health. I think I'll now hand over to Damien for the questions. We've also, Michelle's prepared a really good case study as well.
Thanks, Caroline. Thanks, Michelle. That was really interesting to hear about the clinical management of nutrition in an individual setting in a clinic, dealing with patients one-on-one, and then also from yourself, Caroline, talking about what we can do more broadly with the environments that a lot of our patients often live in. So I welcome our audience to start typing in any questions that they've got for the panel. We've also got Dr. Angela Titmuth here joining us as well. So same as all the other webinars I've run, so type in your questions. You can upvote questions and we'll answer the most popular ones. We will need about 10 minutes for the case study. So we don't have a great deal of time for questions today. So anyone who's got them, type them in now. I can see one in here. Just check, Angela, if you're there. The question relates to what are your thoughts about the use of GLP-1s in the future for adolescents?
Obviously, there's a national shortage of GLP-1 receptor agonists because they've had some great publicity about kind of weight loss and weight management. I don't know if the question was about relating to management of overweight or obesity or whether relating to diabetes, which is obviously a separate issue, and the completely different doses that are recommended for that. I think fundamentally, though, there is a lot of other things going on, as Michelle and Caroline have already highlighted, which are really probably going to be much more effective if we're able to address those kind of systems issues and also some of the main drivers of diabetes. I think it's also important to acknowledge that there's young people with diabetes have different phenotypes. And so young people with type 2 diabetes may not always have a phenotype where there's an increased BMI, for instance, or even increased central adiposity. And in that situation, a GLP-1 receptor agonist would not be at all appropriate because we've actually got a different phenotype and probably more led by in utero exposures and kind of organ programming and transgenerational impacts leading to type 2 diabetes. So there are different phenotypes. They're not all young people don't have the same phenotype, but also acknowledging that there's a lot of young people where if they've been able to change to like diet soft drinks or take away soft drink or sweetened beverages from their diet, have had huge impact in terms of managing their diabetes. And I would suggest that that should be a priority rather than thinking about adding another medication as a first line. I do use GLP-1 receptor agonists for some young people that have very severe obesity, and we've kind of already addressed lots of other changes in their life. And but I think we kind of need to think about system inequity, social determinants, and dietary changes that you can make first as a first line.
Thanks, Angela. Michelle, I'll just check you're still sharing your screen. You might be having a look at something that one of the participants had posted in the chat there, which I think is an interesting thing that people could have a look at after this presentation's done. Just waiting for a couple more questions to come through. I'll pose one to the panel. If you had just a couple of nutrition recommendations to give, what do you think's what would you want people to know for nutrition? I know Angela's talked previously about sugary drinks and the importance of reducing them. I might pass over to you first, Michelle. What do you think are the most important dietary changes that young people with type 2 diabetes can make?
We see significant improvement just by dropping sugary drinks and looking at meal routines. The quality of carbohydrates. So often if we're skipping meals, not having routine meals, we're often consuming the majority of our calories in one meal. And it tends to be dinner. And we then go to sleep. So we're not doing anything, no activity, things like that. So whilst physical activity hasn't been shown to necessarily assist with weight loss, it may be prevented weight gain and improved insulin resistance. Really, it's diet first. Sleep also is a big one, but certainly the sweetened drinks make a huge difference. And as you've seen by some of those statistics, 67% of free sugar was coming from sugary drinks. And we've seen it in clinic with, such a difference in weight loss when we've been able to switch from, even if it's a diet soft drink first before we transition to water, it still makes an impact.
Thanks, Michelle. What are your thoughts, Caroline?
I guess looking at more of the environment approach, like in remote settings, I think addressing food security is definitely the priority to give people access to healthier options. And one of the major barriers that we hear time and time again is the affordability aspect of it. And remote stores are doing everything that they can to keep those prices as low as possible. So I think it really comes down to government stepping in and providing like direct-to-consumer food subsidies, or looking at how they can make food more affordable for people living in remote communities so that they can actually have access to healthy food as a first-line approach. And then I also think what the Healthy Stores 2020 project achieved and the significant results that they showed, particularly in reducing sugar and sugar being sold. So implementing that across all stores would be amazing, because in a lot of remote communities, there is only one store, and some there might be two, but like the store has such a big role to play in terms of nutrition and the impact that it can have on health.
Right. Anything to add, Angela? You're just on mute at the moment, Angela.
I think Caroline's completely right that we have to be addressing the broader issues, the food security, and also the often kind of chaotic living circumstances of some young people. So it's really not just in terms of food security of what's available in the store, but also food security of what's available at their house and in their day-to-day life, and what knowing that there will be food, or what storage. And there's been lots of studies looking at facilities within a home to be able to store food safely, or to be able to prepare food is also really challenging in terms of the housing situation, a lot of remote communities. But then I do agree that young people, I really only focus in terms of, you talk about an individual change, only change I focus on is to try to change to diet soft drinks or reduce sweetened beverages. And do see huge change in the young people that do that in terms of their glycemia and also in terms of weight loss. And I think it's often been programmed for young people to kind of crave those kind of sweetened beverages when you've had it ever since you're very little. Like I often see babies with kind of sweetened beverages, and so that really programs your body to crave it. So it's a really difficult thing to change and requires a lot of support. But the young people that have been able to do it, it makes a big difference.
Yeah. Excellent. Okay, so we've had a number of questions and comments roll in now. So there's a question here. So how can we advocate to governments for these subsidies? I'll start with you, Caroline.
I guess in the ways that we can advocate, Apuna Pima has released a position statement on food security. So I think that's a great place to go for, I guess, more detail and what we're advocating for. But yeah, I think writing to your member of parliament is always a great advocacy tool. I think the political climate is changed, and it seems to be more in line with supporting Aboriginal and Torres Strait Islander people. So they're looking at, the voice to parliament. So I think now is a great time to get behind these sort of issues like food security and to advocate. So yeah, start with a letter to parliament, or if you're part of an organisation, look at putting out a position statement as well. I don't know if anyone else from the panel would like to add anything.
No, but I just think we all do have a role to advocate. I think we need to be strongly advocating for those kind of broader issues, and not just be thinking about our individual patient in front of us, but how we can actually create change. And it definitely is a time where I think there might be the willingness to listen. Yeah.